Post-traumatic stress disorder by Jocelyn Hayes. Post-traumatic stress disorder is an anxiety disorder that a person may develop after experiencing or witnessing an extreme, overwhelming, traumatic event during which they felt intense fear, helplessness, or horror. The dominant features of post-traumatic stress disorder are emotional numbing, hyperarousal, and re-experiencing of the trauma. PTSD is an anxiety disorder. Anxiety disorders cover several different forms of abnormal, pathological anxiety, fears, phobias, nervous conditions that may come on suddenly or gradually over a period of several years and may impair or prevent the pursuing of normal daily routines. The person has been exposed to a traumatic event in which both of the following have been present. The person has experienced, witnessed, or been confronted with an event or events that involve actual or threatened death or serious injury, or a threat to physical integrity of oneself or others. The person's response involved intense fear, helplessness, or horror. In children, it may be expressed instead by disorganized or agitated behavior. Symptoms of PTSD: recurrent and intrusive distressing recollections of the event, recurrent dreams of the event, sudden acting or feeling as if the traumatic event were recurring, intense psychological distress at exposure to things that symbolizes or resembles an aspects of the trauma, including anniversaries thereof. Physiological reactivity when exposed to internal external cues of the event. At least one of these symptoms to be diagnosed with the post-traumatic stress disorder. Forms of PTSD. Acute PTSD, symptoms less than 3 months. Chronic PTSD, symptoms more than 3 months. Although symptoms may usually begin within 3 months of exposure, a delayed onset is possible months or even years after the event has occurred. PTSD diagnosis. There are no laboratory tests to detect PTSD. To diagnose PTSD, a healthcare provider will consider the above symptoms together with history of trauma. He or she will likely also use physiological assessment tools to confirm the diagnosis and involve an appropriately trained specialist. Culture of PTSD can occur at any age, including childhood, and can affect anyone. Individuals who have recently immigrated from areas of considerable social unrest and civil conflict may have elevated rates of PTSD. No clear evidence that members of different ethnic or minority groups are more or less susceptible than others. Onset. Symptoms usually begin with the first 3 months after the trauma, although there may be a delay of months or even years before symptoms appear. Immediate onset, better response to treatment, better prognosis, fewer associated symptoms or complications. Symptoms are resolved within 6 months. Delayed onset is characterized by an onset of symptoms at least 6 months after the stressor. Associated symptoms and conditions develop. Condition more likely to become chronic. Possible repressed memories, worse prognosis. Causes. A person develops PTSD in response to exposure to an extreme traumatic stressor involving direct personal experience of an event. This may include actual threatened death or serious injury, threat to one's physical integrity, witnessing an event that involves death, injury, or threat to the physical integrity of another person, learning about unexpected or violent death, serious harm, or threat of death or injury experienced by a family member or other close associate. Direct traumatic event examples: military combat, violent personal assault, including sexual assault, physical attack, robbery, or mugging, being kidnapped, being taken hostage, terrorist attack, torture, incarceration as a prisoner of war or in concentration camp, natural and man-made disasters, severe automobile accidents, being diagnosed with a life-threatening illness. Observing the serious injury or unnatural death of another person due to violent assault, accident, war, or disaster, unexpectedly witnessing a deceased body or body parts. Prevalence. Approximately 7% of adults in the United States have experienced a traumatic event at least once in their lifetime. Up to 20% of these people will go on to develop PTSD. An estimated 5.2 million American adults aged 18 to 54 have PTSD, or approximately 3.6%. Women are about twice as likely as men to develop PTSD. Estimated risk for developing PTSD based on an event. rape at 49%, severe beating or physical assault at 31.9%, other sexual assault 23.7%, serious accident or injury, car or train accident 16.8%, shooting or stabbing 15.4%, sudden unexpected death of family member or friend 14.3%, child's life-threatening illness 10.4%, witness to killing of serious injury 7.3%, natural disaster 3.8%. Evaluation. More thorough assessments are likely to include detailed structured interviews and psychological tests on which you record your thoughts and feelings. Close family member may be asked to provide more information. Client may undergo a procedure that examines your physiological reactions, including heart rate, blood pressure, plasma measurements, to mild reminders of your trauma. Assessment tools. Two main categories of PTSD evaluations are structured interviews and self-report questionnaires. Interviews. Clinician-administered PTSD scales developed by National Center for PTSD. It has a format that requests information about the frequency and intensity of core PTSD symptoms and common associated symptoms which may have implications on treatment and recovery. The CAPS-1 yields both continuous and dichotomous scores for current and lifetime PTSD symptoms. Treatment of outcome, PTSD scale. It is shorter, it's easier to use, and is highly correlated with CAPS, and which is more time-consuming and less practical for use in clinical practice. Scores. 5 or less reflects no or minimal PTSD symptoms. 7 equals mild symptoms. 15 moderate symptoms. 21 equals indicates severe symptoms. Remission in PTSD should be defined as no longer meeting the diagnostic criteria for the disorder, full functionality, and no or minimal anxiety and depression. Other interviews. Structured clinical interview for DSM using assessment of a range of psychiatric disorder including PTSD. Anxiety disorder interview schedule revised. Structured interview for PTSD. PTSD symptom scale interview. Each has its own unique features. It is important to ask all patients with mental health symptoms about trauma, particularly women suffering from treatment-resistant depression and those with general medical complaints, since patients with PTSD often present with somatic symptoms. Note, although many who experience severe trauma will develop symptoms of PTSD, most individuals exposed to a traumatic event do not develop a psychiatric illness. Why PTSD victims might be resistant to getting help. Sometimes it's hard for people to expect to be able to handle a traumatic event in their life. People may blame themselves. Traumatic experience might be too painful to discuss. Some people avoid the event altogether. PTSD can make some people feel isolated, making it hard for them to get help. People don't always make the connection between the traumatic event and the symptoms, anxiety, anger, and possible physical symptoms. People often have more than one anxiety disorder and may suffer from depression or substance abuse. During a traumatic event, norepinephrine mobilizes fear, the flight response, sympathetic activation, consolidating memory. Too much equals hypervigilance, autonomic arousal, flashbacks, and intrusive memories. Serotonin, self-defense, rage, attenuation of fear. Too little, aggression, violence, impulsivity, depression, anxiety. PTSD victims switch is stuck on. Causal attributions. PTSD is typified by both automatic and voluntary symptoms, flashbacks, intrusive thoughts, autonomic hyperarousal, and consciously meditated attempts to make meaning of the trauma experience. The automatic and involuntary symptoms appear to represent condition responding to environmental triggers associated with the trauma. However, much less is known about the origins and consequences of victims' efforts to understand their traumas or about how best to treat the symptoms associated with personal beliefs about traumas. The most comprehensive and widely cited guidelines for treating PTSD include using variants of cognitive therapy, including attribution retraining and cognitive restructuring. Treatment continued. Acute PTSD, stress debriefing and psychotherapy. Severe acute PTSD, stress debriefing medication, group and individual psychotherapy. Chronic PTSD, stress debriefing, medication, group and individual psychotherapy. For PTSD in children, adolescents, and geriatrics, the preferred treatment is psychotherapy. Exposure therapy, education about common reactions to trauma, breathing, and repeated exposure to the past trauma in graduated doses. The goal is for the traumatic event to be remembered without anxiety or panic resulting. Cognitive therapy, separating the intrusive thoughts from the associated anxiety that they produce. Stress inoculation training, variant of exposure training, teaches client to relax, helps the client relax when thinking about traumatic event exposure by providing client a script. Cognitive restructuring involve teaching and reinforcing self-monitoring our thoughts and emotions, identifying automatic thoughts that accompany distressing emotions, learning about different types of cognitive distortions, and working to dispute the stress-enhancing cognitions with a particular focus on abuse-related cognitions for which the therapist remained alert during the personal experience work. In summary, for women who did not drop out, cognitive behavior therapy treatment was highly effective for achieving remission of PTSD diagnosis, ameliorating PTSD symptom severity, and reducing trauma-related cognitive distortions compared with a WL control group. With treatment, symptoms should improve after 3 months, and chronic PTSD cases can last for many 1 to 2 years. Future direction of treatment continued. Early diagnosis and intervention, either psychotherapeutic or pharmacological following trauma, may someday reduce symptoms of post-traumatic stress disorder. Cognitive models, how the victim understands and appraises the stressful experience, are influential, and cognitive style also helps predict the occurrence of PTSD. Thank you. Hope you all enjoyed.